Hello, dear colleagues. Today we start our roundtable and we greet our participants to this roundtable, Non-invasive oncourology in wartime, experience of SRC Sigulda and needs of Ukraine. We welcome all journalists and everyone who is watching us online. Today, October 1st, we have the Day of the Defenders of Ukraine. So we are thankful to all volunteers, to all defenders, to all soldiers who are defending us today in the front line for this opportunity to be able to get together at this table and to talk about very important issues. So I would like to ask all our participants to round table to keep silence for 1 minute. So let me introduce myself. My name is Natalia Molchanova. I'm a journalist of Ukrinform, and today I'm a moderator to this event. Our roundtable is dedicated to situation with cancer in Ukraine, in particular prostate cancer, and issues how to maintain male health, timely diagnosis of prostate cancer, methods, diagnosis, treatment, including non-invasive, and also opportunities that Ukrainian physicians might get thanks to cooperation with our international partners. And we are talking about exchange in experience, technologies, treatment, etc. Our event is provided as part of the project funded by Ministry of Foreign Affairs of Latvia Republic, Mission Cybernet Sigulda. It's exchange of experience between radio surgery centers Sigulda and Ukrainian medical healthcare facilities to implement cancer programs as part of oncology cluster. And today we have a Doctor of Medical Sciences, Head of Chair of Urology, National Medical University, Oleg Nikitin, Candidate of Medical Sciences, Oncologist, Surgeon Urologist, Head of LISOD, Israel Oncology Center, Serhiy Pryndyuk, Doctor of Medical Sciences, Professor, Head of the Chair of Nuclear Medicine, Radiation Oncology, Radiation Safety, National University of Health, Pavlo Korol, Candidate of Medical Sciences, Doctor Urologist with specialty in oncology, oncosurgery, sexopathology, and sonography, CIS Dr. Andriy Sitenko, Assistant Professor, Candidate of Medical Sciences, PhD, Urologist, specializing in oncology, oncosurgery, sexopathology, sonography diagnosis, Mykhailo Kryshtopa, also the head of the Center of Stereotactic Radiosurgery, Sigulda, Latvia, with us, Skromanis. Welcome, everyone. Greetings. And today also, at our event, we have a simultaneous interpretation into English provided by interpreter Olga Nikolaenko. And I would like to welcome the head of the Center of Stereotactic Radiosurgery, Skromanis. You're most welcome.
Everyone, hello dear colleagues. I'm really thankful to be here, and it's a real pleasure to meet all of you here, because it's not first time that we are in Ukraine. and of course that's very tough time for the Ukraine now and all of you, but you know that the war is not stopping life, so that's why we should do the things which is ordinary things in your life and my life. We should treat the patients, and my introductional speech is about that, why I'm here and why we are here and why this, our clinic is here. And the main idea why we are here is that in 2015 we opened our center in Latvia, in Sigulda, and we start to work in very specific area of medicine, which is robotic radiosurgery. And the strange thing that there is name surgery in the radiosurgery, but there is no any surgery, and we are not performing surgery. And the cyber knife as well, it's knife, but there is no knife, no cuts, no blood loss, no anything, because we performing very precise radiotherapy. And that strange name was given by Lars Lexell, who is neurosurgeon, with gamma knife, with the first system which was introduced to treat very small, very specific tumors in the brain. And today we have as well other meeting, which is in the Premium Rus Hotel, about intracranial pathologies. It's advance of terrestrial radiosurgery in intracranial pathologies. And it's a great pleasure that on this week we will have here a lot of activities with our involvement, with support of Latvian Foreign Ministry, with the grant what was given to us to spread the knowledge about so very specific medicine technologies, very unique medical technologies, very innovative medical technologies. So that's why it's my pleasure to be here. And as introduction, I would like to tell that my goal is here to spread the word about that treatment, which is very effective, very safe, very convenient for patients, and very good because it's keeping there was a nice Ukrainian word sorry, I forgot життя. It's quality of life, but in Ukraine it was яке життя. So the most important thing of my speech is яке життя. Otherwise, there is a lot of treatment options for prostate cancer, for other options which is available in Ukraine, and all that treatments are standardized and you performing them. There is surgery, there is radiation therapy, there is hormonal therapy, systemic approaches, there's different kind of focal therapies and other, but this one, what I'm talking about is not used as many as I would like to use it in your country. So that's why I invited all of you here to discuss about the options and about further steps, how we can get that treatments here. I'm speaking more about very specific part of patients who are in the situation when for them with prostate cancer diagnosis was performed radical treatment and the cancer appears after some period. We are calling it as a relapse. Sometimes it's oligometastatic disease, and the technologies nowadays can help for that patients live much longer, live much better, and live almost without side effects. And that is the treatment where there is two disciplines together. There is needed very specific diagnostic tools like positron emission tomography with specific radionuclides as fluor 18 PSMA, which is available in Latvia, and we started to use that specific diagnostics in 2016, and after that we perform robotic radiosurgery or very precise radiotherapy for patients, and that was our involvement in Latvian medicine, and now we are ready to share all what we did there and the results and our knowledge about that, and to support activities which can support to get such treatments here in Ukraine. So that was my introduction. I hope that you understand the goal of that meeting and our activity in Ukraine, and I would like to give the option to Natalia Molchanova to continue our roundtable discussions.
As I have already mentioned, our roundtable is about diagnosis and treatment of prostate cancer, and there are annual activities with regards to reminding people about prevention and treatment. It happens in October, in November. Still, we decided to talk about that now because it's never late, never early to talk about prevention and timely diagnosis, identification of disease, and timely treatment. Right now, during the large-scale invasion, we can be sure to say that the state is strong and our healthcare system in Ukraine is strong. It withstands it, and diagnosis of prostate cancer is included in the benefits program. However, we know that since 2022, number of prostate cancer cases have dramatically increased, significantly increased. So it could be explained that maybe due to military activities, people delayed their visits to doctors. Also, another explanation that people had to be displaced, go from one place to a different place. They didn't have time and even didn't think about going to see a doctor. Many men have joined armed forces of Ukraine, so it's a very relevant problem today. It's a delayed care of one's health, delayed diagnosis and delayed treatment. According to National Cancer Register in 2023, almost 123,000 of new cancers were registered, which is 14% more than in 22. Also in 2023, for the first time for the whole period of observations, the prostate cancer, not lung cancer, was number one for all cancers in males in Ukraine, and the number of new cases have increased by 25% compared to 22, and that means that a lot of new patients unidentified earlier have accumulated. So the statistics is going to be presented by Doctor of Medical Sciences, Professor, Head of the Urology Chair of National Medical University, Oleg Nikitin. You are most welcome.
За запрошення. По суті, проблеми хочу сказати наступне. По-перше, коли ми говоримо взагалі про онкозахворюваність в Україні з часів повномасштабного вторгнення, слід зазначити, що дійсно у 2022 році кількість виявлених хворих зменшилась, і це створило хибне таке уявлення з приводу того, що їх стало менше. Насправді, із зрозумілих причин страждала діагностика, звернення пацієнтів, надання допомоги, і цим все пояснювалося. Потім, з 23-го року, коли система діагностики, надання медичної допомоги запрацювала, з'явився певний підйом кількості пацієнтів, і це був такий підйом, швидше за все, інерційний, тобто пов'язаний з факторами, які ми вже зазначили. Я думаю, що незважаючи на те, що можна спорити, сперечатися з приводу того, який в нас є механізм об'єктивного контролю, об'єктивізації цих даних, чи дані Національного канцерреєстру, чи дані Національної служби охорони здоров'я, зрозуміло, що за рахунок всього того, що відбувається в країні, відбувається значне переміщення значних мас населення з східних районів у західні, виїзд деяких категорій населення взагалі за межі України, ми не можемо скласти абсолютно об'єктивну картину того, що відбувається. Але, тим не менш, Серед того, що ми маємо, ці механізми, я вважаю, наближають нас до об'єктивізації картини в цілому. Так от, за даними національного
Picture in general, according to cancer registry, the overall number of people of Ukraine who were registered as cancer patients was over 1 million people, 1,100,000. Of course, those were all of those who had cancer in their past history. Those were people that cannot be considered cancer patients any longer, but we have such figures and we have them in National Cancer Registry. It's available, accessible to any person who is interested. What else seems to be quite interesting? Among all that number of patients, only 36% are male, 64% are females. So we have twice as many women compared to men. And newly diagnosed males and females does not differ, maybe 10% different. Thus, annually, approximately the same numbers are registered, but in fact, there are much more women. What does that mean? It means that men die more. And we know that from the point of view of biology, so to say, that women, females, are more resilient. It's just the biology, it's just the genetics, because a woman basically is, we may say, responsible for continuing next generations. But in this specific situation, it looks really very clearly like that. We can say that a huge proportion of males among those who die is related to the fact that morbidity increases and mortality increases due to prostate cancer. It can be quite an objective reason. So number one cause, a lot of patients we have, and males are more vulnerable compared to women. This is number one that I would focus on. Number two is, that was mentioned already before, that for the first time, for many years, for the first time, we see that males are prevailing. There are more males having not lung cancer, respiratory system cancers, but prostate cancer cases, starting from 65 years old and on, 75 and plus. So this is the vulnerable group of males, and they have significant increase in prostate diseases. If we look at the figures in general, so we are not talking about 1 or 2%. That could be reviewed as maybe statistical error, but it's a very significant difference in between genders. And I see that there is a trend that the situation is going to go on, not going to stop, and probably there's going to be a gradual increase in the proportions of prostate cancer patients. And another thing that I would focus on is that 1/3 of new patients last year, so we are not talking about 22, 23, and we have already concluded that these data cannot be objective from the point of view of statistics because of what was happening, but the year 24, to my mind, can give us more objective picture. More than 33% of new patients were diagnosed in with advanced stage, like stage 4 of disease, and every 10th patients, which is more than 10%, have died during 1 year. That's an important piece of information figure, and this corresponds to overall information that compared to Europe and America, we have many patients with prostate cancer who are diagnosed, identified late with advanced stages when it's difficult to provide efficient care and there is high mortality. Another important thing is that we have regions where this figure is much, much higher. And it wouldn't be a surprise if those were eastern regions, Luhansk, for example, and we know why there are problems with care provisions there. But we are talking about the Transcarpathian Chernivtsi region, where it looks like it's not supposed to be there. So there are not two military problems there. In Chernihiv Oblast, almost 50% of patients who are newly registered in care, they already have stage 3-4. They have metastasis, and they have a high mortality level. Thus, there is a big proportion of organizational problems, a poor level of organization of care provision, including diagnostics, and poor level of preventive work and screening of those patients. If screening is done in accordance to the rules taken in the world, like starting from 40-45, screening should be done for each man once a year, and that allows to diagnose the disease if it's there as an early stage, and then the treatment is much efficient and mortality is much, much lower. Another thing, each fifth patient, more than 21%, didn't survive even 1 year after diagnosis, so mortality is quite high. More than 20% of new cases were identified stage 4. That's another thing that I would like to point your attention, that the disease is diagnosed late. As a rule. In general, what else could be said about that strange kind of things also related to organizational level of care is the following, that even in Kiev, there is quite low level of diagnosis for prostate cancer. A lot of patients who even see a doctor, they cannot get high quality care because why? Because the diagnostic possibilities is not up to state-of-the-art standards, so the level of diagnosis is low. Another thing to point out is in the majority of hospitals in 24, we have a statistics line item, there is increase in surgery cases, number of surgeries, but also a strange thing, there's quite a big range from 2 to 56% increase, 2 to 56. We understand that it's not related to the fact that the specialists didn't have any new opportunities for surgery, or maybe they received some new instruments, new methods, maybe robotics was used. And I think that's probably it's related to displacement of specialists. Specialists from eastern part of Ukraine are displaced and they move to western part of Ukraine to work. I know there is such a practice in Rivne. Practically, the whole healthcare facility has moved from east to Rivne, and that is why we have increased. So such surgeries were never done in that center, but now it's done because specialists are there. So there is a big increase in surgeries, number of surgeries. But at the same time, in all cancer facilities, not randomly, but everywhere, in all healthcare facilities doing surgery, from 50 to 73%, of cases, conservative treatment with chemotherapy being prevalent, up to 70%. That's what's seen. How can we interpret that? That's another confirmation that patients come late when surgery is not possible. Of course, at this stage, chemotherapy is done, and radiation methods use rate varies from 1.5% to almost 14%. So it's a big variability in figures, in numbers. I think it can be explained that some facilities have possibilities to do effective radiotherapy, but some do not have such possibilities. At the same time, I believe that this percentage, even if we are taking the highest, 14%, it's quite low with regards to providing care from the point of view of using radiation methods. Thus, if we conclude all that, to make some conclusions, we can say that the number of cancer patients is increasing. Number of male cancers is increasing due to increasing the proportion of patients with prostate cancer. Next thing, in the majority of cases, patients with prostate cancer are diagnosed late, too late, and that complicates treatment opportunities and significantly increases mortality. Level of care provision is very much influenced by the setting and the circumstances that our country has now in healthcare. So there is some disproportion with regards to using different methods of treatment in different places and decreased opportunity to use radiation therapy. At the same time, the opportunity to cooperate together with the Center of Stereotactic radiosurgery in Sigulda, Latvia. This opportunity looks very promising because this project is supported by the state, by Latvian government, and it's aimed at informing doctors and patients about the opportunities to use this method of treatment that this clinic is using, this center is using, in order for the patients and doctors know about this option, about the benefits of this method. And this method has a lot of benefits and advantages compared to other opportunities of treatment that we are using. So I believe it's difficult to overestimate the importance of us talking about that at this event. I see a lot of future in that, and hopefully that colleagues are going to support me in that. Thank you. Thank you, Mr. Oleg. You have voiced, to my mind, terrible figures with regards to 33% of patients last year diagnosed late stages. To your mind, why is happening? How come cancer is diagnosed so late? I understand there are objective reasons like the large-scale invasion, but still I would like to understand how we can most efficiently identify prostate cancer. And you also mentioned about regional disproportion. So what actually causes such regional disproportions? Because it's huge. Thank you for your question. Number one, with regards to diagnosis prostate cancer, we don't have to invent some mechanism. We already know those mechanisms. It's globally used. It's screening for prostate cancer. Why we have poor diagnostics here? To my mind, it's related very much to the specifics, peculiarities of our healthcare system. In countries where we have an existing health insurance system, patients will not get insured if the patient is not following certain algorithms of investigation, examination. So, if a patient would do some test which was incorrect to do, and in other situations that patient wouldn't do that, the system makes him do that test or that investigation. So that actually gives high levels of diagnosis on early stages. And we all know if it's a localized cancer and you diagnose it as localized, it's treated very well. We have lots of examples to that. So the answer to question number 1 is as follows, as I mentioned. So what we can do, how we can counteract this situation that we don't have globally used in Ukraine insurance, medical insurance. So we can only inform people and increase the level of their healthcare culture. So each man has to know. So we have to popularize knowledge, to promote knowledge. So people have to see that, to hear about that from time to time. And another thing, if we had an opportunity to bring this information to men about the opportunity to be tested free of charge, at least PSA once a year, that would also increase the level of diagnostics. Another thing, another question about regional disproportion. It's explained by peculiarities living in this or the other territory and peculiarities of labor. For example, I cannot tell you that I was looking in detail into that issue, but I'm looking at that like that. So we are talking about regions close to the border, like borderline. If it's about prostate cancer, we are talking about men 60 plus most of the time. As far as I understand, due to some economic peculiarities, these men might work somewhere outside of Ukraine, and then when they already have the disease, they can come back to Ukraine, and then they are registered as people with prostate cancer. So that's one of the reasons in affecting this disproportion. So I also think that's also a problem of organization of healthcare. Informing people, screening, again, accessibility, maybe affordability. We also mentioned Transcarpathian region before. A lot of us know that the Oblast center, the capital, is very far to the west. Eastern regions, they might be 200 kilometers away from the capital, so you have to go through over the mountains. So maybe it's not the most important factor, but it's there. It's mountains there in Transcarpathia, but we have to discuss that and how we can influence. What we can influence is informing people, spreading knowledge, informing our colleagues. Even our discussion today is also, to my mind, is another step to overcome that challenge. Thank you very much. You also mentioned that only from 1.5 to 14% of prostate cancer patients undergo radiological radiation treatment. As far as I understand, there are other methods of treatment, and I would like to invite candidate medical science oncologist, urologist, head of modern Center of Israel LISOD Urology, Serhiy Pryndyuk, to talk about that. Dear colleagues, thank you. Thank you, Natalia, for introducing. Thank you, Maris, for inviting for such a high representation roundtable. And I'm sure that the main goal of this event is going to be achieved. We will inform our colleagues, inform our patients, and we will reach our goal in future 100%. We will create a cancer cluster that's going to be aimed at improving cancer care in Ukraine. Of course, I would like to greet our defenders with this day of a Ukrainian defender. Thanks to our defense forces, armed forces, we can have events like that to be held. And just to continue with our discussion, I have this opportunity now to tell how little invasive treatment methods, and it's not only about surgery, allowed us and are allowing us to do a lot since Since the beginning of large-scale invasion, there was a shift in care provision, and the previous speaker has mentioned that there was some decrease in diagnosis opportunities and possibilities, and when there is diagnosis suffering, then treatment suffering too. So many invasive methods allow us, and they are aimed at quality of life of our patients. Besides, as I have mentioned, at the beginning of large-scale invasion in 2022, the main focus was on care provision to wounded soldiers. So that was number one. It was combat injury or combat trauma. So different surgical options were used to patients who had blast explosive injuries, so on and so forth. And cancer patients, unfortunately, were kind of neglected, and the stage of their disease was advancing. In our center, we never stopped providing cancer care, but of course, it needed that we change our logistics a little bit. At the same time, cancer patients had an opportunity to get chemotherapy, surgical treatment was available. Also, we were working as a military hospital as well. Maybe it was related to the fact that our center is located in the southern part of Kiev Oblast, so maybe we didn't suffer too much in the beginning of 2022 because other centers were closing. But we made a decision that cancer patients will still need their care, and we didn't want to close our center because reopening would be much more difficult. And we are talking, first of all, about radiotherapy methods, and I would like to talk about how line accelerators are working, and that allowed us to continue providing radiotherapeutic care, considering the effectiveness of many invasive methods and logistics. We started to use hypofractionation methods and ultrafractionation methods in provision of radiotherapy, and that allowed us to decrease the time of the sessions and the patient time and avoid other difficulties related to prolonged patient stay in hospital. With regards to chemotherapy or target therapy, our guidelines, clinical guidelines, allow us to look at different options. If we're looking at prostate cancer, for example, metastatic setting, patients with hormone-sensitive prostate cancer might get chemotherapy and target therapy pills, tablets, and we paid attention to logistical things and where treatment with target drugs is possible without the need of patients staying in the hospital. So that also something that we did very much. And also at the same time, the metastatic prostate cancer patients also received the treatment. So that allowed us to avoid situations like that. So when the patient couldn't get chemotherapy in the hospital, but on an outpatient basis, target therapy was possible for him to get. So efficacy of treatment was the same. And besides, due to the fact that we had some stock of chemotherapy agents and stock of target agents, immune agents, thanks to the work of our medical supply department. So there was not stock out in 23, beginning in 22, 23 in targeted systemic treatment options. Going back to surgical options, so many invasive approaches, and we are talking laparoscopic operations and endoscopic operations, allows us to shorten length of stay, recovery, rehabilitation of patients, and of course they are aimed at quality of life improvement. And this is something that is paid attention to much more. And in clinical guidelines, there is a special section talking about quality of life. So no doubt that is of paramount importance. Besides, if we go back to logistical issues and care provision to patients from other regions, important thing that cancer patients have to get, for example, systemic therapy all the time, like non-stop. And when there is need to evacuate patients, they're evacuated to safer regions. But our outpatient target therapy, or, for example, care provision as on a daycare basis, allows to maintain the patient on the same regimen and do not disrupt the chronology, the timing of the process. And also, before large-scale invasion and after large-scale invasion, we are using telemedicine, telehealth elements, considering that we are cooperating very well with Israel centers. We have tumor boards on a weekly basis, discussions of difficult cases. We are discussing difficult cases, and that allows us to take correct decisions to patient benefit. Why I touched upon telehealth approach and strategy. In fact, we already cooperate with Sigulda Center, but after today's meeting and after having more information for doctors and the patients, for sure, this cooperation, of course, is going to be aimed at quality of life of our patients. First of all, what we are talking about, hypo and ultra hypofractionation or radius surgery methods that allows us to decrease treatment duration. That's where the local therapy is needed, so-called non-invasive methods of treatment used that are viewed very positively by young patients because for them quality of life is of paramount importance. And at the end, I would just like to touch upon the importance of genetic testing, because we all know that more and more of cancers are closely related to genetic factors, inheritance. So that is why testing patients is important. Those patients who have a genetic risk factors, it's important to understand the genealogy, and the patient has to know about his relatives, first-line, second-line relatives, what kind of cancers they might have had. That allows to do genetic testing as early as possible, to look at risk factors, to look at inheritance, and then maybe precision or target therapy might be prescribed, because the future is personalized medicine. It's not one pill for all, but it's a targeted pill for a targeted thing. So genetics and molecular diagnosis is going to help us in that. And we are trying, and also we are sharing this experience. With regards to genetic testing, molecular diagnosis, it should be done on the first phase, not waiting until the patient is advanced, when this precision and target therapy or immune therapy, if needed, is not worthwhile to be offered to the patient, when it's difficult to hope that that's going to be effective. So the future is of personalized medicine, regardless of the realities that we are living through now. Of course, it's a martial law that we are having, but oncology, cancers do not disappear. Patients continue to be sick. Unfortunately, as the previous speaker has mentioned, we see patients in advanced stages. But we need to still continue with what we do, provide care to our cancer patients in a personalized approach. Thank you, Mr. Serhiy. You have described this problem so broadly. It's really interesting, but I would like to ask you, you have mentioned a little bit how you worked during the beginning of large-scale invasion. So according to your experience, which methods of treatment for your patients at this period of time when there were some logistical problems and probably there were problems with drugs, supplies? Well, I understand you had some supply, but still, what was the most effective for your patient? And what do you think? So maybe because some patients with cancer, including prostate cancer, had to, because of large-scale invasion, had to discontinue treatment or chemotherapy or delay surgery, whether that impacted people and their perspectives, their future, and possible recovery. So that's something to think for everyone. Thank you for this question. That's true. What we faced is that during the first months of large-scale invasion, a big proportion of patients was evacuated and also evacuated, some of them evacuated abroad. And we had some feedback and we know that they faced some difficulties being treated abroad because they have a certain system in other countries. And first of all, it's about the patients who were registered there, but they had to wait for a long time. They were on the waiting list, so they had to be in line. For example, wait in line before they could see an oncologist. Those were months, sometimes many months, but the disease is not waiting. It is progressing. Some patients were forced. They had to go back to Ukraine just to continue their treatment. So there was a proportion of patients like that. Again, answering your first question, we cannot say that there is only one effective option of treatment that worked during the first year of war, and we can say that this option is the best. Each patient has his best option, and we looked at the realities and we tried to use the method of treatment that the patient needed. For example, if patient needs radical surgery, then using mini-invasive methods like laparoscopy, we shortened the length of stay of patients in the hospital, and thus there was less burden to the system. If a patient needed radiation therapy due to hypofractioning, decreasing number of fractions, we also decreased length of stay. Patients who were prescribed were indicated to have systemic treatment, and if it was possible to do it on an outpatient basis with target drugs, compared to inpatient chemotherapy. So that option was used. And then the patient, even if he was in a different part of Ukraine, they could get target drugs on an outpatient basis. So it was different for different patients. But I believe we were able to make it as efficient as possible for each particular patient. Thank you for your experience. I wish every success in your work. It's really important, valuable to us. Thank you. As it was already mentioned during our roundtable, and Mr. Oleg has mentioned a big problem that cancer is diagnosed late. And there are objective reasons for that and subjective ones. Currently, our state is trying to implement screening programs and equipment is being procured for diagnosis as well. And now I would like to talk about PET-CT as a diagnostic method. I would like to invite Doctor of Medical Sciences, Professor, Head of the Chair of Nuclear Medicine, Radiation, Oncology, Radiation Safety, National University of Health, Pavlo Korol, to talk about that. Greetings, dear colleagues, friends. Thank you very much. Natalia and Mr. Maris, thank you for getting us together in this wonderful place for such a powerful event. My talk is going to be about hybrid visual imaging and nuclear medicine interdisciplinary approach in combating clinical problems. So, of course, urologists and nuclear medicine, radiation oncologists need to cooperate to test patients. That's a key task in order to overcome clinical vague situations. Couple of figures. In 2024, almost 7% of all new cases of cancer had an unidentified stage. So that's even worse during wartime, especially in regions that are under huge pressure, Mykolaiv, Odessa, and other regions. The proportions of cases with an unidentified stage is 17 to 18%. We have to say it's not just a statistical drawback gap, but it's a problem when doctors need to make decisions with regards to treating without having full diagnostic information. Current methods of radionuclide hybrid imaging like single photon emission, tomography, positron emission tomography together with CT, thanks to metabolic component, powerful sensitivity provided by PET-CT and the structure provided by CT, it's a very relevant instrument to do something about this unidentification. These methods to make it possible to stage, restage, look at metastasis, bone metastasis that traditional imaging methods might not see. Also, they will allow us to look at therapeutic response, etc. And that allows for correct planning of treatment and and incorrect treatment. A special focus is on efficacy and safety of radiotherapy methods when treating urology tumors. So current radiation therapy requires fewer sessions and it will give less complications compared to radical surgeries. So in conclusion, I would like to assess the experience of using state-of-the-art radiation therapy methods in Ukraine with limited resources and under martial law, and we also, under such conditions, we are showing that such radiological technologies could be safe and efficient solution to our patients. So the priority should be for implementing such things as robotic radiosurgery, cyberknife, and current radionuclide diagnosis of PET-CT. these technologies is not only clinically efficient but more rational in the setting of limited resources, because they decrease treatment time, they decrease number of complications, and they preserve quality of life, which is strategically important for a country in war. Thank you for your attention. Thank you, Mr. Pavlo. I have the following question. As long as government is planning to procure cyclotrons, so maybe can you tell us somehow more about the development of this direction in Ukraine? So the question is, in order to do such testing as PET-CT, PET MRI, in order to work with different pieces of equipment that is provided to hospitals now, in order to work with equipment that we have in private clinics, we need specialists, professionals. And as long as you are working in an educational facility, so maybe you could share your experience whether currently, whether it's popular, whether there is a big need in specialists, such specialists, how many of them we need, if you can estimate the need, and how do you train them, how many of them we have already trained, if you have data like that. Thank you. Thank you, Ms. Natalia. A very interesting question with regards to the need. According to the recommendation of WHO, for 1 million of population, we need one positron tomography equipment. For our country, we have to have about 30 of such machines. Right now, we have 4 PET systems in our country. Unfortunately, they are all in Kiev, so 3 public ones, 1 private healthcare facility. Not enough. Of course, it's not enough. And we don't have enough cyclotrons that are producing some radio drugs. In our country, we can use only 1 nuclide. Nuclide is fluoride, and we can use it with different compounds. So 2 cyclotrons. And the hospitals having the PET scanners have to be in line to wait for this radiological drug. And to my mind, we are doing something about that already. We are looking at the issue of creating a national cyclotron, manufacturing national cyclotron. So to my mind, we need at least 3 just to cover for the center, east and west of Ukraine. But we need to start at least from something. Also, there are some suggestions to build at this point of time 2 powerful cyclotrons, 1 in Kiev, 1 in Lviv, and for those cyclotrons, 3 or 4 PET scanners also would be used. So these are the plans as of now, and they need to be developed. They need money to be put into that. Second aspect, professionals. To work with positron tomographers, cyclotrons, of course, we need specialists. And it's not only having healthcare education, but also medical chemists and physicists is something that we need. So what we have done and what we need to do more. In 2024, there was a team of specialists that got together. We already developed 2 specialties according to European requirements: nuclear medicine, radionuclide diagnosis, and radiation oncology instead of radiation therapy. So in Ukraine, we already have specialties, like 2 disciplines, the correct ones, not the Soviet name specialties, but current European specialties and disciplines, and we can train relevant specialists. And this year, in our healthcare, in our educational facilities, so 28 radiation oncologists and 6 specialists of nuclear medicines were trained. So we already training people with those specialties. We need more because there is a need, there is a demand. New centers are opening, equipment is being procured, line accelerators, etc., positron tomography machines. So, of course, there is a need to train specialists. What needs to be done? We need to develop a medical physicist specialty to be developed in Ukraine, and people like medical physicists need to be trained according to relevant curriculum. It's an even bigger problem is motivate chemists, chemistry specialists, and we need them to work with cyclotrons. It's even more relevant challenge. And at the end, also, I would like to give us a suggestion. Today we are talking about PET-CT with current tracers, with prostate-specific membrane antigen. And we have a war in our country, and we don't have a lot of PET scanners, but there is a way out. To my opinion, a very interesting idea that needs to be developed is as follows. Needs to be developed not only in Kiev, but in other regions. Odessa, Mykolaiv, Kharkiv. They have a lot of nuclear medicine departments. And they have single photon tomographers and gamma cameras. PSMA, prostate-specific membrane antigen, could be compounded not with fluoride, not only with gallium, that's not certified in Ukraine, but technetium 99M as well. So, and these technetium generators is something that we have enough. We have lots of such generators, and gamma camera factor is something that we do have in Ukraine. So probably we have to look in this direction. And as of today, to my mind, it's the way out to work with technetium, PSMA, and do sensitive and specific imaging. So to my mind, the way out of this situation is something that we can offer. So that was mentioned before. Develop nuclear medicine, develop interdisciplinary approach, the radiation, oncology, nuclear medicine, urologists working together to move on. So that's my answer. Thank you very much. At the same time, some clarification, and maybe it's not only an answer from you, maybe some other experts would like to answer. As long as PET-CT is one of the ways to diagnose that we are using, so for whom this PET-CT is indicated more. So if a person learns about his cancer diagnosis, whether that person needs to go to undergo PET-CT scanning, or PET-CT should be done in some other cases when a person have undergone some treatment and there is some confirmation of this or the other result is needed. So can you clarify? Because for us, as you, Mr. Pavlo, has mentioned, it's not a very widely used methods of diagnosis as Ukraine, but if PET-CT is going to develop in Ukraine, so who is it for? It's true. A very good question. So each conference has a question like that. PET-CT is a costly method. Specialists know about that method. It's indicated, it's like a cherry on top of the pie. So you've done CT, MRI, and they say, well, let's try PET-CT. It's not always correct to do so. Sometimes it could be more cost-effective. Spectral emission or single photon emission tomography is sometimes enough. Scintigraphy sometimes is enough. The main value of positron emission tomography, to my mind, is assessing therapeutic response after systemic or radiation therapy, because due to metabolic component, we can see inhibition of tumor cells activity. So a person has undergone certain of phases like chemotherapy, radiation therapy, and so with the structure method, we will see changes. Maybe in 6 months, maybe in 1 year. On a metabolic PET-CT method, in 2 or 3 weeks, it's quite possible to see inhibition in tumor cells activity. So glycolysis was 100 hypothetical. In 3 weeks, it's 40. Or maybe it was 100, but it became 300. So in 3 weeks, we already can see where we are moving to radical treatment or local therapy. So I think the main value of PET-CT is assessing therapeutic response. That's number one. Staging, restaging, looking for metastasis, but to my mind, it's assessing therapeutic response. That's the main thing. That's the cherry we are talking about. Yes, and we have to explain that to specialists, not only to radiologists, to others as well. Yes, please, if you would like to add. Yes, I also would like to add to answer, because it's about interdisciplinary team approach, and it's about oncology strategy or direction. Unfortunately, there is a myth that people sometimes think we have PET-CT. It's a method that covers all issues. And very often patients come and they say, well, you have PET, let's do PET. And they believe it's the best diagnostic method and it'll give you answers to all questions. But it's not the case. It depends on tumor localizations. There are some sensitivities, some tracers, some radionuclides that are specific to this or the other tumor localization. If we are talking about prostate cancer, it's PSMA, gallium, that's we don't have in Ukraine, or fluoride as of today. So to my mind, the indication to PET, PSMA, and I agree, it's the response to systemic treatment, if we want to look at that. But if the patient is undergoing staging only with that method, so he is doing PET-CT on a regular basis, then it could be compared. If he did CT 3 or 4 months ago, and now we are trying to do PET, so for a radiologist, it would be difficult to do any comparison. With PET-CT, there is a computer component, computer tomography component, but still it has to be one and the same method to be compared. So radiologists pay attention to that. So response to systemic treatment, if this method of diagnosis was used before, and also to my mind, staging in a new patient should be done with PET-CT if we are curious about radical treatment and local forms of prostate cancer, because as of today, it's clear that this method of diagnosis is costly, but very often computer tomography and osteoscintigraphy would not give you the answer whether there is metastasis or no metastasis. And sometimes with CT and osteoscintigraphy looked like no metastasis, but with PET PSMA we saw the systemic disease, and that changed the strategy of treatment dramatically for this patient. So it's not an additional method after CT and osteoscintigraphy, but it's number one for staging, if possible. Of course, we understand that our possibilities are limited, and if we don't have that possibility, routinely we do CT and osteoscintigraphy for staging of prostate cancer. And number 3 is biochemical relapse. So if a patient, after radical treatment, has increased PSA, and we have to find the cause, of course, it's PET PSMA that would allow us to get the answer, although there might be some discrepancy when MRI, for example, a practical example, MRI does not see local relapse in pelvic area, but PET PSMA shows accumulation of radionuclide, or vice versa. that also happens. It's very individual for each patient. So concluding, PET PSMA has its indications, and we need to targetedly use them, not for everyone. Thank you. So whether I understand it correctly, so if a patient comes and says, I want PET-CT, it's not always that the doctor would do that. Doctor needs to understand and see whether there is indication for this method or some other method could be used. Also, I would like to add on top of that, as of today, we have very good results using whole body MRI to look to see metastasis of prostate cancer. We have this experience in Kiev, in Ukraine, so we don't have to forget about that as well. And we have specialists who were trained how to interpret, how to read the results. So just a small remark. Thank you. Thank you very much for this remark, Mr. Andriy Sitenko. Next, I would like to give the floor to Maris Skromanis, one of the founder and the head of the Center of Radiosurgery Center in Sigulda, Latvia. As long as we have different types of cancer and diagnosing and treating cancer from invasive, mini-invasive, radiosurgery, a broad spectrum of radiosurgical treatment, I would like to ask Mr. Maris to tell us about such a method of treatment as CyberKnife, about experience of Sigulda Clinic, experience treating patients with prostate cancer with the CyberKnife technique, and also a very important aspect of patient life as quality of life, and what's happening to a patient after treatment or during treatment, how much time is needed after treatment to recovery or to improving health status. So you're most welcome.
In the beginning, I would like to tell or make small remark about the previous topic. There is one magic thing what every patient of prostate cancer has to know. It's the PSA, because we are starting every journey of a patient with PSA evaluation. So if you are 50 years old and you never perform the PSA test, it's very easy just to give your blood in laboratory and to perform the test, and you will get the answer. If the answer is like normal, after a year you can do it again as like technical examination of your car, which you are performing every year. I hope in Ukraine you doing that every year, but in Latvia we are doing it every year, and you are getting back the information. Yes, you're healthy for prostate is okay, there is no worries, you can live and enjoy your life, and there is no problems. If there is elevation, you should find the doctor who you trust. It's urologist. You should visit first time in your life the urologist, and he will support you and tell you, because the PSA doesn't mean that you have cancer. It's the sign which shows that yes, there is some problems with your prostate, which is very specific and very important organ for every man, and then you will find the reason of the PSA elevation. If that elevation is higher and or it's a sign of cancer as well, the same trusted doctor, urologist will guide you how to solve that problem. And if you will find it early, there is many options how to treat your problem, and the most of them are very effective, safe, and good ways how to avoid and to live long and how to be in good shape after even the treatment. And then if even you have aggressive cancer and after the traditional treatments or first-line treatments or radical treatments, it appears again the PSA level is what show that yes, there is problem. The sickness is still there. The possibly cancer return, again the same doctor, the same urologist, the same trusted person will guide you how to solve it. And in that particular case, the PET PSMA is important, because without PET PSMA, we doesn't know where exactly that cancer appears again. But with PSMA, PET, we have like visual example where exactly, and then when you know exactly where is it, you can or treat it surgically, or to use the radiotherapy, or to use our method, which is as well radiotherapy, but very precise, ultrafractionated radiotherapy. Sometimes it's called as radiosurgery. And as I told in my speech, we performed the treatment of many, many patients in Latvia and Lithuania and in Ukraine, and that is like third year we are starting to treat the patients from Ukraine, and the results are the same as in Latvia and Lithuania, and we are very thankful for support of Ukrainian doctors who can offer for some patients the treatment, because unfortunately the treatment is not paid by government, and the patient should pay it by themselves. But you know, sometimes it's really important who is driver your life, or it's your willingness to live long and live with good quality of life, or the other things which is important to you. So what can I tell about the Sigulda? We are from Latvia. It's very small town, very nice, where is located our clinic, and we are open to Ukrainian patients, because one of the best neurosurgeons who is expert in neuroradiosurgery is living and working in our clinic. That's Dr. Vladislav Burik, who came to our clinic in 2016, and with his connections we start to treat the patients with intracranial or head pathologies, and now with the kind support of my colleagues, doctors in urology field, what we are here, we see as well the patients with urology pathology, like mostly the prostate cancer. But here we are about that we should have that opportunities to see where the cancer is spread, where we can find it as well in Ukraine. So I hope that in soon future you will not spend, and as well our government will not spend huge money for military things, but we can buy and we can purchase the systems which supports patients, which gives additional years of life, and we can treat patients much better.
Thank you very much. And our next thing to discuss, here I would like to invite Mr. Andriy Sitenko, candidate of medical sciences, urologist, specializing in oncology, oncosurgery, sexopathology, ultrasound diagnosis, and city doctor, clinic doctor. Mr. Andriy, here I would like to focus during our conversation on the following: reproductive health, saving, quality of life, before, during treatment, after treatment, and maybe you also might tell us about the situation in Ukraine, as long as we heard this quite significant statistics. And I was asking about data from NHSU as of the year 24 and 25. So last year in 24, we had more than 205 new cases of cancer registered within electronic database of NHSU. More than 18,000, those were new diagnoses of prostate cancer. And for this 25 year, as of March this year, we already have registered more than 140,000 cases, new cancers, and 12.7 thousand is prostate cancer cases. To your opinion, what this increase related to? It's underdiagnosed cancer before, or are those causes that we already discussed before, or maybe it's because of diagnostic challenges, so not challenges, but improvement in diagnosis, regardless of the war. Maybe diagnosis is improving, so maybe some screening is working. Floor is yours. Thank you. First of all, I would like to greet all my colleagues at this wonderful event. Thank you, dear Natalia, Mr. Maris, Cyberknife, Sigulda Clinic. Thank you for inviting. Of course, thank you to all our defenders for the opportunity to be able to freely talk now and provide important information to our communities and public. Still, I would like to comment and to start my speech saying that that's true. We are all fighting for time. And Maris has mentioned that we would like to add years of life. Very often when we are trying to prolong life, we forget what kind of life, whether it's a quality life, whether it's life that is related to disability, and maybe the patient suffers of this type of disabled life. So these are important aspects. Going back to your question, with regards to increasing rates of prostate cancer in Ukraine. Ukraine and should not be some kind of specific enclave with regards to increasing rates of this disease. Compared with Poland, for example, about 20,000 of new cases are registered annually there. And regardless of the fact that they don't have any wars, that their insurance system is very well organized and healthcare system in general is quite well organized in Poland, they have the same challenges with regards to diagnosis, for example, and most probably that can be explained by the nature of prostate cancer. I would like to point out that over the last 15 years, we have dramatically changed the prostate cancer patient profile, and our thoughts about what is prostate cancer has changed. In order to treat a patient and prolong life, we need to understand who are we treating. Are we treating a man from 52 to 75 years of age? Most of them, it's physically usually active man, a sexually active man. Yes, he might have reproductive plans at this age. Of course, we should think about that. This man has 95% chance to live longer than 15 years since the prostate cancer diagnosis. And more, what do we know about cancer? Out of the big cancer cohort that is diagnosed, the insignificant part is deadly, lethal. So at the same time, patient has more chances to die due to cardiovascular diseases with time rather than non-aggressive prostate cancer. So these changes in our understanding of cancer define the agenda for a current urologist. If we have a simplified look at the situation, our task is not to miss lethal cases among those cases that are diagnosed thanks to PSA, because PSA is like a two-faced Janus. It's both beneficial, it's useful, but there is some negative side to it. It's excessive diagnostics or hyperdiagnostics, we call it. If we treat non-aggressive cancer patient, the patient would get all types of complications but no benefits in terms of survival. We really need to understand that. So first we need to define whether it's a deadly, lethal cancer, then if it's localized form. So it's limited within the prostate. We need to choose target precision treatment to affect only the cancer cells. So why we are talking about this issue? So why we are coming from the radical nephrectomies to resections, and we are fighting for each millimeter for healthy parenchyma in kidney? How come the same paradigm is not used in treating localized prostate cancer in cases when we want to save urination function or retention? We want to preserve the ability of a patient to have sex, to have orgasm, to ejaculate during sex. All that is lost by the patient if he was treated with radical prostatectomy. Moreover, it's almost like a criminal news. We learned it from recent publication of a very respected magazine, medical magazine. So it looks like if we take 3 groups of patients that we are treating with help of radiotherapy, radical prostatectomy and observation, so 3 groups, so respectfully, in 5 years, mortality does not differ at all. No difference in mortality. It's another confirmation and the fact that we should not be radical. We have to be precise. Again, going back to the agenda for the urologist who faces the localized prostate cancer. Number 3 is prognosis for relapse. Unfortunately, we do not know. Even the tumor is very, very excessively small. We do not know when this tumor, if it's aggressive, if this strain, this clone is aggressive, and there's seeding, because there are some micrometastases. The tumor might be 5 millimeters, but at the same time, metastasis might be into bones, in lymph nodes, and it can be proven by a simple fact. When after radical prostatectomy, for excessively small tumors, in some time, in 10 to 15 years after that, first there is biochemical relapse, and then very quickly we find metastasis, we start treatment, and sometime after we see a castrate-resistant problem. So what do I do in my clinical practice? How do I tackle all those 3 general aspects? What do I do about them? So how do I manage patients with localized prostate cancer? In our clinic, in City Doctor Medical Clinic, we have 2 innovative technologies used. It's precision navigation within prostate technology. So MRI imaging and sonography imaging are combined, Badger technology. So we can take precisely a tissue from suspected lesion, any localization in prostate. So there is improvement in diagnosing lethal cases by 30%. It's very important when in one kern, in small tumor, you see aggressive cancer and you can treat it right away and preserve prostate. And second technology, you mentioned gamma knife, cyber knife. It's our technology is nano knife. It's electroporation, non-reversible. It allows to precisionally destroy the tumor, retain the urination, retain erection, and already have cases when we treated local cancer in patients, a cancer that relapsed after radical prostatectomy and radiotherapy, so two methods were used, and after that nano knife was really effective. Also, we have cases of efficient treatment of locally advanced prostate cancer. Precision imaging is the way toward meeting needs of our patients, not making them disabled. Number 3 thing that is important. Any high qualified urologist with experience understands that if he faces lethal, aggressive cancer, even a small tumor, and even if he provided very efficient treatment, relapse is possible. And that's part of our prognostic calculators that we are using. So we might already give the prognosis when the relapse might happen. So what's the risk? So you have to have plan B, C, D, and sometimes E. So plan B for me is CyberKnife. Why? Because I also see patients with castrate-resistant metastasis. So I see such patients in my clinic, and if we can stabilize the disease with anti-androgenic therapy, the next step might be using therapy aimed at metastasis. And here, CyberKnife is a unique technology, absolutely unique. The last example of our cooperation with CyberKnife Sigulda Clinic showed that we can grant not just life to a patient, but quality life. I already told Maris about this case when a patient with metastatic castrate-resistant prostate cancer came to me 1 year ago, and he asked 3 months of delay to complete his business, his life things that he had to complete. So thanks to innovative anti-androgenic therapy, we were able to stabilize his condition and to reach involution of the majority of metastases, but still 2 of them were still active and even demonstrated progression. After that, the patient, considering having a good effect of anti-androgenic therapy, was referred to CyberKnife Clinic in Sigulda. He underwent a course of treatment, so his PSA is 2.9 and 9, and then according to PET PSMA, he is fully stabilized of 20% of metastasis and involution of 80% of metastasis. And the patient is calling me and asking, "Doctor, how come I'm feeling weakness? I need to do my business." So when he saw the results, when he started to believe in that therapy, his priorities, life priorities have changed. And also why I wanted to again mention the Sigulda CyberKnife Center again. Mr. Serhiy, my respected colleague, mentioned the importance of multidisciplinary approach when we manage patients with prostate cancer. True. Well, it actually is about any type of cancer. If I'm referring a patient to Sigulda, I understand that I'm not just a passive observer of treatment process. I'm an active player. We are discussing complicated things together. We define targets. We communicate with regards to treatment results, treatment outcomes. So that means it's a continuous information exchange. Analytics, it's really important for the results and for satisfaction, patient satisfaction. So right now I would like to say and congratulate all Ukrainians saying that they have this opportunity to be treated in Sigulda CyberKnife Clinic with help of precision stereotactic radiotherapy. They have this opportunity to get additional benefit, and it's better not to use the power of 3 rings, but the power of 2 knives. Hopefully, we will continue to cooperate to the benefit of all our patients. That's a tremendously important initiative that we really need to unite our efforts of all urologists, oncologists, radiation therapists, radiologists, because without radiologists currently to do focal therapy or to do a precision diagnosis of prostate cancer is not possible. It's impossible. In 2018, the European Urologists Association focused attention saying that each urologist needs to know how to interpret MRI, to understand what is T1, what is T2 weighted, what is DC, what's diffusion, to analyze, to review, and work together, like in pair with a qualified radiologist. So there is ongoing evolution, ongoing improvement. We've started from diagnosing prostate cancer just digitally. Then we are using PSA. Currently in Poland, they identify lethal cancer when PSA is 1. Yes, it's really important to do genetic screening. It's important to understand who needs to undergo this testing, because as I mentioned, PSA might lead to overdiagnosis. If a person might die due to complications of radical prostatectomy, that means that the whole system is a huge gap. Thank you for your attention. Thank you very much, Mr. Andriy. You know, when I was showing this statistical data about morbidity in Ukraine, you said that our data compared to Polish data. Then clarify, please. Make it more clear. Some people, they usually believe that the war, military activities lead to the fact that this or the other disease morbidity is increasing. We know for sure that the number of cardiovascular diseases is increasing. We are saying the same with regards to oncology. Look, there are different factors leading to that, but nevertheless, according to NHSU, 18,000 last year, and you say 20,000 new cases in Poland last year. Of course, we cannot. Well, it's approximately, yes. Well, compared to cases per certain population, because in Poland, they have about 36 million, so 36.5 million population, but they had migration, more people coming there, but we are losing population due to military activities, people leaving to going abroad. So with regards to your question, again, we need to go back to the biology of prostate cancer. Prostate cancer has so-called lead time. So that's a kind of a latent period before symptoms appear. And this lead time usually is 10 to 15 years. So if we understand the biology of prostate cancer, we can make a conclusion that the situation that's happening today, it has its continuation, will be having its continuation, and will be shown maybe in 10 to 15 years from now. Maybe the military activities now will affect this lead time, but again, time will show. Nevertheless, let's put it this way, the problem of oncology and psychiatry is one of the most relevant problems of humanity. Even before the active military activity started, we've been to a conference that was 2020. That was a European Sexual Medicine Association, and at that time the WHO was providing information to different associations with a request to prepare recommendations to treat two categories of patients: cancer patients and patients with psychiatric mental diseases. So back at that time, the prognosis was that cancer and psychiatry and mental diseases are going to be the most relevant problems in healthcare globally. Thank you very much. As Mr. Andriy has mentioned already, I just remember this phrase that each urologist needs to know how to interpret MRI data. So to learn new methods, to get trained, and that's probably not about the urologist only, but any healthcare worker, because we have lots of new technologies. Of course, we will have to deal with them. So I would like to ask and give the floor to Mykhailo Kryshtopa, the Associate Professor Candidate of Medical Sciences, urologist with specializing oncology, oncosurgery, sexopathology, and ultrasound diagnosis, head doctor of Grál Clinic Medical Center. Mr. Mykhailo, maybe you can tell us, with regards to the following, how the current healthcare workers might get trained, increase their qualification, advance their knowledge. As we heard from Mr. Koval that we have two new medical specialties, and we know that doctors are trained using certain curricula, then they have to work, get experience, they learn, see something new in their professional life. Can you share, please, your own experience, what a current urologist need to know and be able to do, oncologist? Thank you very much for your question. Greetings to everyone, and I would like to thank you, our defenders, and also I'm very thankful that I have this opportunity to express my opinion with regards to different issues. Thank you, Ms. Natalia. Thank you, Mr. Maris, for this opportunity to work together, to discuss together in a wonderful group of people and team of people. What I would like to say, it's true. Technologies do not work without people. Of course, we can buy PET-CT for all regions, even CyberKnife. At the same time, we understand that without a doctor, as Dr. Andriy has mentioned, without a doctor who knows how to use it and knows how to interpret the results, it's just going to be useless. And that's what we see. We observe that in our country as well, when state-of-the-art equipment is just sitting gathering dust not working for years. And not only in different regions, but even here in Kiev, I know that in very well-known high-level public clinics, they have very costly equipment sitting idle because there is no specialist who might work with this equipment. So the main challenge as of now is not just having the equipment, but training specialists. So this is the investment into human resource. Since 1996, I've been working at the chair of postgraduate education. And during that long period of time, I've been observing how postgraduate education is evolving. And to be able to train our doctors, we also were trained as part of our urology association. We've been trained in different European urology clinics, how to train, how to teach. So what I should say, we have to switch from the model of just reading lectures, giving lectures. Currently, it's still very widespread in our universities, towards hands-on training. So this hands-on training gives much more result. And in 2 weeks, it might get much more results compared to just lectures. So MRI, sonography, fusion, radiosurgery, other methods mentioned by other previous speakers is something that will be integrated into practice, and each doctor needs to have the knowledge how to interpret the information that he is getting. For example, when I was at Maris' clinic, and together with Andriy, we have been to a gathering in Riga in the cancer center. It was like a concilium, like advisory board. We saw that all specialists working there, they know every piece of information that they are getting. So each doctor is very knowledgeable. For example, we have Sigulda Cyberknife Clinic in Latvia. They are treating our patients, so their experience can be a foundation for the systemic training of Ukrainian urologists. So 3 levels cooperation are offered at a short-term training in Sigulda to learn about cyberknife radiation therapy. And also its advisory boards of different cases together with our Latvian colleagues are going to be held conferences, including into our specials into European discussions, and other countries as well are offering support. Poland, Lithuania, and Czech Republic, they are ready to get our specialists to get trained in their centers. So there is it's not that we are stopped, it's just our desire that we need. And of course, we would like to create a cancer cluster in Ukraine with a center hub, regional hubs, Lviv, Dnipro, Odessa, telehealth system, distant remote consultations, protocols, unification of protocols according to European and American Urology Association guidelines. Currently, they are using different approaches. That is leading to that discrepancy in results mentioned before. And telehealth. Currently, we have up to 30% of oncourologist specialist consultations are done remotely. In Ukraine, it could be implemented very quickly. It's just we need the standards. The formula is simple. Human resources, technologies, and then it's going to be sustainable. And at the end, I would like to mention that Ukrainian oncourology requires investment into expertise, just like investment in equipment. What does that mean? That we can save hundreds of lives annually, not just by standardization, good training, but international partnership training programs. And training has to become a priority of the health and the key strategy of international cooperation. So to create a current state-of-the-art oncourology system in Ukraine. Thank you very much, Mr. Mykhailo. Thank you, everyone, for your speeches, for your words. I would like to ask a couple of questions. It's for all of you. Maybe from your own experience, you might say whether you see prostate cancer becoming younger, because we know about cardiovascular diseases, they become younger, so they're diagnosed in much younger people now, not just as we. I believe that all our colleagues see such processes. It's a trend that is global. For example, 10 years ago, I thought that I would never see prostate cancer in a patient younger than 40. But now, I already had a patient younger than 40 with PSA1. He had very aggressive cancer that was very difficult to treat. And we lost this patient, unfortunately. Regardless of all current diagnosis methods that we have. So cancer is getting younger. That's the problem that we will be facing in future more often. Whether I understand it correctly, that pertains not only to prostate cancer, but in general cancer. Or, well, prostate cancer, it's a disease related to age. It's more related to age. So the first place globally disease that men are dying due to is cardiovascular pathology. But when we started to treating cardiovascular diseases really well, our patients now are surviving until they get prostate cancer. So after 80 years of age, we are not doing any screening, but we understand that in a patient older than 80, we already have the prostate cancer. So it's an interesting situation. Age, our patient age is becoming higher, so people live longer, meaning so people live to 80, 90 years of age, and I have a patient that I was working with, and his age was 102 years of age, so people live longer. So with age, we understand that prostate cancer is there. So patients live long enough to see the prostate cancer, but the problem is different. It's getting younger. So it's easier with age. So if we live long, for example, if we long till 90, we will have prostate cancer, but usually it's not clinically significant. But at the same time, the disease is getting younger, and for them it's significant because it's a young man with high level of testosterone. Yeah, and usually the prostate cancer is hormone dependent disease. It's a big problem. Here we need to work more. So that's why we are saying that in cancer or oncological cluster, and that we need it. And as of today, this problem is not only a problem of Ukraine, it's a global problem in Poland and others. Altogether, we need to look for some solutions. So what are we going to do about that? Thank you very much. I also would like, so maybe colleagues, you might give some general recommendations. What men should do, starting from what age, which doctor to see, what kind of tests to undergo. And if, forbid God, this diagnosis is made, so what's the pathway, the journey of the patient? Because usually people are scared, men are scared. Women are more thinking about their health, but men do not. Men usually withdraw inside themselves and they leave it for future. But unfortunately, they delay things. Unfortunately, that might lead to poor results. So maybe I would like to ask you to provide some general recommendations to our men. I'm not going to stop at some standard regular things. What I would like to say, one problem to mention that we see is men in general, when they feel well, they don't want to see doctors. They don't want to come to hospitals because they feel healthy. And they don't want to acknowledge that they might have some kind of a disease. So we need to do something to create information campaign, or some areas with information have to be established for men to understand that he has to take care not only about his car on a regular basis, like to replace oil, and do something else, but he requires that maintenance as well. For example, the center where I work was established related to the following problem when I saw, and it's not only in our country. I've been to Berlin. I was at the training in Charité Hospital, and when I went to the admission department, I saw that it looks like a financial office, like people sitting at the tables, like paramedics sitting at tables. They see women, older people, older men and women. And I saw when girls enter and they just leave. And I was asking, where do girls go? Which doctors do they see? And they say that they're ashamed. They don't. They are shy. There is a special place for them. Where's men? There is no men. Men are not coming. So we have the same situation. Because today, of course, we can say we need to do PSA, we need to do the sonography or something else. Many other things need to be done. But first thing that we need that man to come to see a doctor. So that is something that we need to do something about, for men to understand that it's necessary. But other things are quite just regular things, and my colleagues probably is going to say what's necessary to be done for our participants. And hopefully other people will also watch that, not just journalists. Thank you. Yes, you're most welcome. Thank you for this wonderful question. It is truly directed at some programmatic issues to continue discussion about the cancer becoming younger. If we look at statistics, it is younger. First of all, it's related to improved diagnosis. So we identify cancer much better now compared to how we did it in previous 10 and more years. And it looks like that the cancer is getting younger because we see it in younger patients. Also, genetic inheritance actually it matters. And there are guidelines, and according to guidelines, patients who have genetic predisposition, they have to start to control their PSA 5 years earlier than for general population. So for general population, it's 50 years when they have to start. For those with a genetic predisposition, 45. If it's a young patient, we need to suspect genetic cancer and test genetic mutations, do molecular diagnostic, because probably it is going to be genetic predisposition that we will find. And usually young patients with prostate cancer, they usually have not high PSA. Usually it's associated with very aggressive prostate cancer that is very difficult to treat. So in simple words, the younger the patient, the more aggressive cancer he might have, and that means very complicated to treat. For such patients, we need to be even more thorough. What needs to be done? Of course, there is a certain algorithm for such patient testing. Age, when PSA needs to be started to control. I've already mentioned, if there is a suspicion, the patient needs to undergo all phases of diagnostics, and that should be done by a qualified, highly trained specialist. If there is a suspicion, there should be MRI of prostate done. Radiologists have to interpret that, and doctor oncourologist also needs to interpret that together with the patient, do a discussion to see whether there is indications to biopsy, prostate biopsy if it's necessary. Also, I would like to focus attention that regardless of this boom, so to say, that we have in MRI fusion biopsy, target biopsy as well, I believe that to some extent its role is somehow overestimated, and it's quite more practical to do combined biopsy, because combined biopsy when we do MRI fusion and target biopsy, and in parallel we do biopsy from standard points. We do the histological staging by doing that, so we understand how the disease is involving different localities of prostate. So it's local staging, and that allows us to define the option for radical treatment, including those options that were discussed today, which is focal therapy or radiosurgery or radiotherapy. So biopsy needs to be done in the correct way. Indications also have to be defined not by hyper-diagnosis, like over-diagnosis, because too much biopsies might have a negative impact. Some patients are afraid of this invasive, so has to be by indications. And then the correct staging needs to be done for prostate cancer. So we have to prove or disprove metastatic disease, confirm or confirm absence, because this will allow to define the correct treatment options. PET PSMA helps us in that as an ideal staging instrument. If it's not possible to see for sure, more routine methods are used, and then we are defining the most optimal option if it's a local disease or locally advanced. So there are options of radical treatment that will allow the patient to be treated. So that's briefly about the journey. Thank you very much. Thank you, everyone. So our time is over, actually, and we need to finish at that. Just in conclusion, I would like to say thank you very much for your work. Thank you for the opportunities that you are providing to our patients in treatment, in leading healthy lives. As we have understood, there are lots of different ways of diagnosing, treating, and different combinations of these ways, and we are happy that Ukrainian doctors are open to international cooperation, that they're ready to get trained to share their experiences. I'm sure you have a lot to share about your experience with our international partners. And of course, if you might take additional technologies and use them in your hands, that is wonderful. Thank you, everyone, for your participation in our roundtable. All the best to everyone.